So once again, we're pleased to be bringing you to this IHSPR policy round focused on genetic testing and related health services. The policy round is made possible through the collaboration of the Michael Smith Foundation for Health Research, the BC Ministry of Health, McMaster University, and CIHR. And the project you'll be hearing about today was supported in part by the Institute of Health Services and Policy Research and the Institute of Genetics. So just a few words about the Institute of Genetics. I wanted to mention that the Institute of Genetics, some of the work that they're doing, and one of their three major priorities relates to the work of this project. The Institute of Genetics has established a priority and planning committee for the research priority related to health services, policy, and ethical and legal social issues research. Their efforts are focused on designing initiatives and activities that will explore important theoretical, methodological, and practical health services, policy, and ethical, legal, and social issues in genetics and genomics. So I just wanted to highlight this and mention if you want more information about the work of this institute and this strategy, you'll see on your screen now a link that's appeared, and you can click through for more information. So the learning objectives of this particular session, I'll just go through them quickly. They are to recognize the opportunities and challenges of governing genetic tests and related health services, to learn evidence-based elements of a comprehensive approach to governing genetic testing, and to understand existing research gaps. We'll explore BC's journey with genetic testing services, and to share genetic testing best practices and questions. So this particular project is as a result of an integrated knowledge translation approach that has been a foundation for the EIHR initiative, thus ensuring that the research conducted truly supports policy and decision-maker priorities. So you'll be hearing today from a few different perspectives, a researcher perspective, policymaker perspective, and a service provider perspective. So as an outline for how the session will unfold, we'll do some quick speaker introductions, provide some background and context from the BC perspective. You'll hear about an overview of the research, and then more about the policy implications from the BC Ministry. And then we'll finish the session with questions and answers using the chat mechanism that we talked about earlier. So the presenters today, the first of the three panelists you'll hear from is Heather Davidson. She is the Assistant Deputy Minister in the Health Sector Planning and Innovation Division with the BC Ministry of Health. Heather joined the ministry in 2010, and she was previously the Assistant Deputy Minister for the Ministry of Housing and Social Development. She's played a number of senior roles in the BC Public Service over the years, and prior to that, she's worked as a psychologist providing clinical psychological services. She holds a PhD in psychology. With Heather is John Andruschak. He was appointed to lead the consolidation of pathology and laboratory medicine services in the Lower Mainland in 2009. In addition to this ongoing initiative, John is responsible for the Provincial Blood Coordinating Office and the Provincial Infection Control Network. Prior to this role, John was Vice President, Corporate and Clinical Services at the Provincial Health Services Authority. He has extensive healthcare experience spanning over 28 years, including previous roles as the Provincial Director of the BC Perinatal Health Program and Director of Health Services in Fraser Health. And last but not least, we have Michael Wilson. Mike is the Assistant Director with the McMaster Health Forum. He's an Assistant Professor in the Department of Clinical Epidemiology and Biostatistics and a member of the Center for Health Economics and Policy Analysis. He's an investigator with the Program and Policy Decision-Making at McMaster University. Mike's research is focused on supporting the use of research evidence in health systems with a specific interest in community-based organizations and health system managers and policymakers. So I'm going to turn it over now to Heather and John to speak a little bit about the British Columbia context, And so I'll ask Heather to take it from here, and thanks again to everyone for joining.
Our microphone on? Okay, so hello and good morning, everybody. Thank you for inviting us to come and speak about this project. So, you know, we hear a lot in the media and in the literature about the rapid development of genetics and genomics, and you know, we recognize the many opportunities that this creates to improve patient outcomes. Currently in BC, it's a relatively small portion of our budget. We estimated it's about $30 million a year that we spend on genetic testing, which is not nothing, but out of a $16 billion budget, it's a small portion of what we're spending. But already even with relatively limited genetic testing going on, we can already see that there would be challenges if this field began to expand and increase in possibilities for genetic testing, and recognize the need to, if we could start early on, relatively early, to actually develop appropriate processes for how we would, set priorities, what kinds of policies did we need to have in place, what the decision-making tools and approaches did we need, and that we knew we needed to do it with our health system stakeholders. Can you flip the slide? Great. So some of the challenges that we have presently, and we could see if we didn't kind of get a handle on, would continue to create problems. We have multiple providers of genetic testing services. We do have a provincial laboratory system or genetic testing program at the Provincial Health Services Agency where Don works, and he'll be talking later. But it was also being provided through fee-for-service, physician payments, lab payments, through some of the other health authorities have begun developing their own capacity, and the technologies, and I'm not an expert in this, but I know that there's different kinds of technologies like cytogenetics and molecular diagnostics and things like that that were sort of popping up all over the place without any coordination or rationale. We have multiple funding models, as I said, that we have some fee-for-service payment, we have some global funding and some provincial funding, and how people get access to these different services is very much not coordinated. And really, in the fee-for-service world, almost any physician could order these lab tests without necessarily having a lot of information or properly informing patients or have the ability to actually counsel patients on what the results meant for them. We know that's a substantial part of genetic information, is that people need to actually understand what it means and what they can do about it. And that brings to the whole ethics and equity issues around genetic testing and what it means. I mean, increasingly people can also, and are in BC, ordering their own genetic tests online through, 26andMe and those kinds of organizations. So just thinking about, again, that we could, if we started early, put in place the proper mechanisms that would help us manage this better going into the future. So that was really our rationale for requesting this policy review through McMaster and IHSPR.
Good morning. So one of the things that I wanted to cover off, so it's was essentially the need for the ministry and probably government and key health system stakeholders to begin that collaboration on both planning, priority setting, and reforms to kind of maximize the benefit and minimize some of the outcomes and the undesirable outcomes and the costing. The challenges are really, when considering it, is largely arising as genetic and genomic genomic and genetic testing is largely due to the expanded understanding and the role of genomics in health and disease. So where more candidates are being identified from every aspect of medicine, and while there's been an exponential decline in some of the cost per test, the aggregate cost has been skyrocketing because of threshold changes and greater volumes. So, other inward challenges that we're facing with these multiple providers, there's a number of genetic platforms being established to address both inherited diseases, acquired diseases, to address drug sensitivity, infectious diseases, and disease risk factors, all of which are competing for capital, human and financial resources. In most cases, it seems to me it's almost relatively easy to get into the game, but very difficult for us to sustain as resources are constrained. So skilled staff can be difficult to find. Technology is rapidly changing, keep the next gen sequencing, all in the face of limited revenue. So we also have competing experts and priorities telling us how this should be organized. We've got divergent technologies, and it's a very peculiar requirement to continue to do the old test now that we have a new test. So if the new test is effective, and in most cases better, a reassessment is necessary, and let's stop and remove the old platform. Or what we have is we have similar platforms duplicated in multiple labs. So high operating costs, and as many of you know, the efficiency in genomic technology comes with scale. So you can sequence a single nucleotide or a whole genome or a few genes at a time in a panel. And a lot of sequences at the same time make it more cost effective. So we also in support the bioinformatics infrastructure does not have to be duplicated, and actually could in fact benefit from working together. Diverse test menus, there's an entire complexity in trying to bring these test platforms together. Different uses, different needs. To discover inherited or acquired mutations, you sequence human DNA. Within microbiology, a human DNA, but a single organism is sequenced. There's multiple, and Heather covered this as just multiple funding models and pathways. There's a real lack here for us is a true programmatic approach to genetic and genomic testing. And given our limited resources, how do we direct those resources to the most appropriate, either existing or even new genetic tests? So we believe that there's a real need for almost a health technology assessment, health test assessment, if you will, a process that can help us tell which tests have been validated on whom and when. And that combined with a priority evaluation structure can help us prioritize those resources based on evidence, the science, validity, and bring them into the test menu. So as Heather mentioned, in BC at the moment, we have 3 primary routes. People through the back door, fee-for-service application, core budget realignment, and even a program for out of service. So people are trying to get these tests done through a variety of means. There is also this need for the coordination with other services. A good example of the difficulties arise when we have approval of cancer therapy that requires companion genetic testing. So without the full cost implication being understood, there's a failure in the system. And so programmatically, we need to coordinate with the specialties, and one partner cannot be in front of the other, creating either an upstream or downstream issue. I think that's called the whack-a-mole phenomena. Patient informations. We really are facing a lot of, in many circumstances, patient acquiring information on Dr. Google or Oprah, or even the gray literature now demanding that tests be validated, preventing us that tests aren't being validated or the system is even not ready to support this. Patient immediate demanding access to research discoveries as are reported in the newspaper. With more molecular testing will come the need to educate the public, primary care clinicians to provide and support the counseling and work with the patient. From an efficiency and sustainability factor, the most dramatic factors that have driven this trend have been the proprietary genetic tests, with some of them with 4-figure price tags. And in the past, the lab tests would cost cents. Now the test costs be up to about $5,000. And previously, in the lab environment, you could almost be under the utilization radar. Now everyone is examining lab utilization as a priority, largely because of some of the findings around genetic testing. And on the other hand, the need for genetic tests used to support precision medicine ensures the right pharmaceutical and will in fact save the system money. So analytics is becoming a new aspect to this whole source of sustainability. Ethics, and Heather mentioned that again, and even becoming more pronounced and into the public debate after the recommendations from the American College of Medical Genetics and Genomics, which recommended incidental findings be reported. So the recommendation that labs to provide germline exome or genome sequencing all for analyzing report on pathogenic mutations in 56 selected individual genes. And that sparked a very public debate, as you know. The impact on the patient, the burden on the lab to seek out these variants. So again, the impact of that is really brought into the forefront. Quality, ensuring that the tests are valid and quality assured. Proficiency programs haven't really caught up to genetic laboratory testing formats. Bringing together experts and service providers, bring them together and have them work not as separate individuals, but to be able to kind of ensure that as one gets brings forward demands, the other one is able to respond. From a total outward perspective, this whole issue around a diverse economy or growth development, so it's this opportunity to really look at the opportunity around international competitiveness and effective use of the health resource. Next.
Okay, thank you, John, and thank you, Heather, for that context. And I'll ask all the participants just to hold questions for now until the end of the session. We're now going to hear from Mike Wilson with some of the details about the project that was conducted. And so, Michael, we'll pass the ball to you and hear about the project.
Great, thank you, Jack. I'm just wondering, I don't have control on this one. Okay. Great. So as Jennifer said, I'm going to talk about the synthesis and the stakeholder dialogue that we convened at the McMaster Health Forum about coordinating genetic tests and related services in British Columbia. And so John and Heather both spoke to some of the context around that. So I'll elaborate on some of that. But up front, I just wanted to flag, so I'm not an expert in genetics or genomics or anything like that, but my role and the role at the forum was to provide a synthesis that tried to package the policy relevant issues around the problem and to identify three elements of the potentially comprehensive approach to address the problem and implementation considerations, and then engage 18 to 20 participants in a stakeholder dialogue to constructively discuss and deliberate on each of those different components of the brief, and then to also to identify next steps for different constituencies. So in general, the presentation, I just want to spend a little bit of time on going over the planning process that we had to give you a sense of what we did, and then give you the key findings, just very high-level points from the evidence brief. So on the slide, it should say evidence brief and not issue brief, and then key findings from the stakeholder dialogue. In terms of our planning process, all the dialogues that we convene at the McMaster Health Forum use a steering committee, and in this case, our steering committee consists of a number of different partners, one from the BC Ministry of Health, the Provincial Health Services Authority, from UBC, as well as from the University of Ottawa and Toronto, and us at the McMaster Health Forum. So their role is to collaboratively engage in a series of free dialogue teleconferences to collectively guide the development of the evidence brief, and also to identify potential participants for the stakeholder dialogue. And then after the dialogue is held, to provide feedback on the dialogue summary that we write up about the main themes that emerge during the day. So it's meant to be a very collaborative and iterative approach with partners throughout the project. In terms of the evidence brief, in case you haven't heard of them before, I just want to run through some of the main features of what we do to write an evidence brief. So in general, it's our effort to mobilize research evidence about the policy context around a particular issue, and then more in depth about the various factors contributing to the problem. So is it at the level of a risk factor, disease or condition, programs or drugs being used, at the level of the health system. And then we craft three elements of a comprehensive approach for addressing the problem. It could be drawn upon in whole or in parts or sequenced in different ways to address it. And then also we provide implementation considerations, but we don't provide recommendations, with the idea that we wouldn't want to preempt any of the deliberations by providing any sort of recommendations within the brief. So key distinguishing features of the briefs are that we try, wherever possible, to draw on systematic reviews, and in particular in our workup of the three elements of an approach for addressing the problem. And then we draw on more local data and studies, to work up the problem to provide that more contextualized information about how the problem is affecting the specific jurisdiction that we're focusing on. And then the purpose of the brief is meant to be an input into the discussion rather than just a standalone document. So it's meant to inform that day-long deliberation that we had during the stakeholder dialogue. Okay, so moving on to the key findings for the brief, and with respect to the problem, ongoing planning, funding, delivery, and evaluation of genetic tests and related services, we identified as facing a number of different challenges. The first is that demand for genetic tests and related services, as John and Heather were talking about, seems to be growing exponentially. This includes increased availability and affordability of tests in general, as well as being used for a broader scope of both rare and common diseases and conditions. So part of this is the innovation that's taking place around genetic tests. So, for example, they're available for more than 2,500 diseases. And it could be more than that, as well as coupled with this is the investment that's happening in continuing to develop new genetic tests, and then also the enthusiasm or the hype behind genetic tests as being being sometimes viewed as a medical panacea. And then in addition to this, the second point, the growing demand really means that there's increased pressure on current programs and services. So while the overall budget amount, as Heather was saying, might not be huge in proportion to the overall health budget, the growing amount is placing increased pressure on existing programs and services. And then in general, current programs and services lack coordination to try and grapple with this increased demand, which further limits their ability to efficiently respond to those emerging pressures, and especially for common diseases and conditions. So on this slide, gaps in health system arrangements within which genetic tests and related services are provided are also a key feature of the problem. So at one level, our delivery arrangements. So one piece of this part of the problem is the lack of overarching regulations and guidelines for the delivery and quality assurance, for instance, in laboratory and non-laboratory services. And then also the lack of coordination and communication across providers and settings. Which could include that one possible reason behind this is the lack of a gatekeeper role within the province that can help to coordinate across a range of providers. And instead, what was viewed through some of the key informed interviews that we did to inform the development of the brief is that many providers can order tests without much coordination across the province or regions. At the level of financial arrangements, there's generally a lack of coordinated funding and reimbursement models to support a reorganization of existing resources. So, for instance, funding decisions at the time of writing this brief were largely localized and often viewed as being done through global budgets or through fee-for-service systems. So, each of those comes with different incentives or disincentives. For instance, with fee-for-service being that you need to use tests that already have a billing code, whereas there could very well be a cheaper version of it or a more appropriate test that could be used but doesn't yet have a billing code assigned. And at the level of governance arrangements, in general, lack of robust medical and administrative frameworks and processes to inform coverage decisions, policy decisions. So some of this speaks to regulatory issues, and one of the main things that came out, one example is the direct-to-consumer test, where there's a lack of regulation, and also was highlighted in the literature as having important implications in terms of the downstream costs as a result of the direct-consumer test. So those are the main features of the problem. I mean, they're all written up in much more detail in the brief, but I'm just giving you the highlights of what we wrote up. And then for the elements of the comprehensive approach, the first element that we presented in the brief was to develop a comprehensive policy framework for the ongoing planning, funding, delivery, and evaluation of genetic tests and related services. So within this, we typically include several sub-elements that could contribute to an overall package for it. And in this one, we had appointing a government task force to develop a comprehensive framework to support policy and coverage decisions regarding genetic testing and services. establishing a central administrative gatekeeper or hub to coordinate decision-making and deployment of resources, establishing monitoring and evaluation mechanisms to support the government's role in financing delivery, strengthening capacity in health technology assessment for genetic testing services, developing increased capacity in health human resource planning for genetics, and a strategy to inform, consult, and engage consumers and relevant stakeholders in governance. So in terms of what we found from systematic reviews was unfortunately not much. So the number and quality of the reviews that we found was quite limited. We did find one review to support a strategy to inform, consult with, and engage consumers, which specifically found that training of patients and healthcare professionals is an important component for successfully involving patients in research, policy, planning, and practice. In addition to that, we found some reviews, but unfortunately, found some reviews about the gatekeeper hub piece of the element, but unfortunately those reviews found insufficient evidence one way or the other to support establishing that type of structure. However, one of the reviews was focused on the context of the United States and related to the application of pharmacogenomics. And across the studies included in that, there's consensus for guidance and regulation of pharmacogenomics, and that the FDA was viewed as being the appropriate central agency to lead efforts to address those challenges. So some of the ways in which they operationalized that were through advisory groups, intra-agency collaboration, and clear and transparent regulatory policy, including things like provisions for making decisions on a case-by-case basis. And then in addition, another review that we found indicated that collaboration across multiple agencies is largely difficult and potentially expensive, but that successful collaborations that they found in the studies required common objectives as well as a monitoring and evaluation plan to ensure that the objectives of that collaboration are being met. Unfortunately, we didn't find reviews on the last 3 points, establishing monitoring and evaluation, strengthening capacity in HTA, and developing increased capacity in health and resource planning. So the second element was focused on developing a quality framework for genetic tests and related services, and a package of sub-elements within this one were related to establishing mechanisms to support coordination and integration of services, increasing opportunities for education and training for health professionals in genetics and new genetic medicine, better evaluating supply and demand for genetic specialist services to link to credentialing processes and link those to credentialing processes, strategies to support the implementation of regulations and guidelines for quality assurance, implementing quality monitoring improvement systems, and funding and remuneration mechanisms for services. So what we found from systematic reviews, so we found more research evidence here. Some reviews spoke to findings related to the licensure requirements. And in particular, one review found that social, academic, and financial support during pre-licensure education of health professionals was found to sustain student enrollment and graduation. So it's one mechanism that could be drawn upon to better support an optimal supply of specialists in a given area. In terms of supporting behavior change related to clinical practice, we found a number of different reviews that are available, and some recent and high quality ones found benefits in terms of for audit and feedback as an intervention, so assessing what's been done in a practice versus what would have been recommended based on guidelines or best practices, and then comparing it and feeding it back to the providers of the practice to help improve what's being done in the future. A range of educational interventions, such as distributing educational materials, holding meetings, or doing educational outreach visits, and then also reminders and prompts, whether it's through electronic medical records or otherwise. And then lastly, one review found small effects in 6 of the 7 studies that it included for financial incentives to improve the quality of care. So one option to support optimal care. And lastly, for the third element, it was focused on developing a framework to support consumer and patient family decision-making about genetic tests. So that we only had 2 sub-elements within this one that were broadly focused on involving consumers and families in decisions. about genetic tests and as a way to encourage them to express their beliefs, values, and preferences about treatments and care. And then the second one was about decision aids and support systems for consumers and patients about screening and treatment options. So we found a number of reviews about this. So both high and low quality reviews found that more consumer involvement led to more current, relevant, and easy to read materials in general, improved the self-esteem of consumers and patients and families, and improved the organizational culture and made the organizational culture supportive of patient involvement more generally. And then also with respect to decision aids, we found several reviews that indicated that those types of systems improved knowledge of screening and treatment options, patients' involvement, realistic perception of outcomes, communication accuracy, risk perception. So some fairly broad-based outcomes and some good evidence behind them as one potential strategy to engage consumers. And then at the level of implementation considerations in the brief, this was more of a brainstorming exercise on our part and our steering committee to identify potential barriers to implementation. So the barriers can be viewed at the level first of patients or individuals. So for example, it could be the asymmetry of knowledge and expertise between patients and citizens and providers, or frustrations with past experiences related to genetic testing. At the level of providers, a barrier could be the perceived infringement on autonomy or lack of awareness of shared decision-making approaches. At the organizational level, perhaps one barrier we flagged was making decisions in the context of media hype and the difficulties encountered with doing that. And at the system level, challenges of cross-provincial coordination and standardization is one piece of the options that might pose a barrier for implementation. So that's the brief, and then, so as I mentioned, the brief is an input into the dialogue. So as an overview, a quick overview of our stakeholder dialogue and features, the stakeholder dialogues are our mechanism of allowing research evidence to be brought together with the views, experiences, and tacit knowledge of those who are either involved in, affected, or affected by future decisions about high priority policy issues. So it's having the research evidence as the input, and then having deliberations among key stakeholders about what are the key features of the problem, what should we be considering for options, what might we need to think about in terms of implementation, and what are some constructive next steps that can be taken either collectively or individually following the dialogue. So the two key features of the dialogues are that we follow the Chatham House rule, and for those of you who aren't familiar with it, it means that participants are free to use the information received during the meeting, but neither the identity nor the affiliation of the speakers nor that of any other participant may be revealed. So what this means is that a participant in the dialogue can come and feel as though they can speak freely because what they say cannot be attributed to them individually following the dialogue. So we do share common themes and issues that came up, but we don't attribute that to any specific person. So it allows them to speak very frankly, when normally that doesn't often isn't able to happen. And we also don't aim for consensus, with the reason being that there's a need to allow for divergence of opinions to foster a truly constructive discussion about what to do. In terms of the participants, we choose participants based on two broad criteria. The first is that they're able to bring unique views and experiences to bear on the challenge and learn from the research evidence and others' views and experiences. And the second is that they need to be able to champion within their respective constituencies the actions that will address the challenge creatively. So that's how we work with the steering committee to select people for the dialogue. And for this one, we had 20 participants, of which 3 were policymakers, 5 managers, 4 healthcare providers, 1 consumer representative, and 1 researcher. And then we also had 6 individuals with experience in other provinces to help share lessons learned. In terms of the deliberations about the problem in the stakeholder dialogue, so many participants agreed that the key features of the problem included, which I covered earlier, the exponential growth in demand for tests, the lack of coordination, and the gaps in existing health system arrangements. But they also identified 3 features of the problem that were viewed as being unique to genetic testing related services. And the first was, which I raised earlier, the direct-to-consumer testing. and the associated regulatory issues and the downstream costs that come as a result of the direct consumer testing. Another was the media hype, and with genetic tests and genomics being portrayed as a medical panacea, but with little effort met in the media to educate and inform people about what it actually means. And then the last was the rapid pace of technological change. So the example given in the dialogue was the whole efforts towards whole genome sequencing. And that, and then, so moving to the next slide for the problem, dialogue participants also highlighted a number of features of the problem that are not unique to genetic testing-related services, but where the consequences of them might be felt particularly acutely in this specific policy. So the first was a mix of funding and remuneration models. And the second was a lack of robust frameworks and processes to guide the evolution of testing services. And lastly, the gaps in research evidence regarding the clinical validity and utility of tests. So some of these were covered a bit earlier. In terms of the deliberations about the elements, for element 1, we found among the dialogue participants, sorry, just to back up for a second. So in general, dialogue participants supported all 3 of the potential elements of the comprehensive approach to address the problem. So I'll just go through each of the 3 very briefly. For element 1, largely everyone was supportive of a framework that could guide decisions in BC regarding who gets what, where and how, and who should pay. However, within those deliberations, there were some differences of opinion about the scope. So this, for instance, whether to address all genetic testing-related services immediately, or whether we should build up the framework by working through the issues raised by a particular disease or a test. There are also differences in opinion related to the process, so whether the process for its development should involve few or many people, and whether it should be a time-limited task or a formalized body. And then lastly, differences in opinion about players, so whether only experts or a broader array of stakeholders, so for instance, including the public, should be involved in developing the framework. For the second element, related to the quality framework, participants emphasized the need to adopt a particular focus on education and training of health professionals in genetics, and as part of that, providing an adequate supply of trained people in the area. The potential role of genetic counselors in supporting education and training of other professionals was viewed as being very important. Developing simple guidelines about the whens and whys of ordering genetic tests. So one way that this has come up in a subsequent dialogue about supporting optimal screening approaches that we just ran about a month ago was viewing things in the context of the patient's journey and what should we be doing along different points in that journey, and taking into account the different contexts and issues that each person individually might be facing. Also, participants spoke to the need for quality assurance in laboratories and the need for a unifying quality framework. And then several participants within that last point spoke to the high likelihood that such a framework could be developed given the inherent willingness that was observed among stakeholders to cooperate on that type of approach. For the third element, supporting consumer, patient, family decision-making, so participants viewed this particular one as critical, and especially in the context of direct-to-consumer testing and media. In developing that framework, it was really emphasized that it shouldn't be done in isolation from healthcare providers, that they need to be engaged in the process. There's a general need to support patient self-education. An example given was guiding people to existing and highly rated sources that exist, and then using national collaboration in this type of effort. In terms of implementation, there were 2 key barriers that were identified during the deliberations. The first was the perception that the issue isn't on the government's agenda. So participants questioned whether efforts should be focused towards raising awareness about the urgency of the problem, examining alignments between the elements of an approach to addressing the problem and existing provincial initiatives, or making sure that everyone is well poised to take advantage of both foreseeable and unforeseeable windows of opportunity. So some examples that were provided were the laboratory reform process and the health technology assessment infrastructure that was being developed at the time. So Heather might be able to speak to some of those a bit more. And then the second barrier was the degree to which the BC and Canadian experts who could contribute to this type of process are already overcommitted. And some suggestions were revolved around someone playing a convener role, and CIHR was suggested as one possible group for playing convener role for a pan-Canadian approach. And then lastly, about next steps. So the deliberation about next steps included a few requests to the ministry. One was to convene senior staff, so for example, the 5 assistant deputy ministers within the ministry, to discuss potential next steps. And then for the ministry to continue to update dialogue participants about the potential next steps so that their individual efforts could support and add value to those next steps, so ensuring a collaborative approach moving forward. And then, lastly, using a collaborative or consensus-based approach, but with the recognition that the ministry would eventually have to be the one to make the policy decision. And then lastly, for next steps, other stakeholder groups and contributions from those stakeholder groups included possibly playing an impartial convener role for either a framework or quality framework, identifying and working with potential participants in the framework development process, generally raising awareness among funders, supporting education and training initiatives, and involving other provinces in doing this. So that's it for the key findings for the brief. I just very briefly want to bring your attention to a few resources. So on our website at the McMaster Health Forum, so mcmasterhealthforum.org, all of the resources from this project are freely available. So under our products page, you can go in and download the 2-page topic overview, which gives you links to all the products associated with it. Or you can download the evidence brief, which is identified there, as well as the dialogue summary. So there are 2 standalone documents, the brief and the dialogue summary. Then there's also a number of video interviews with dialogue participants that were willing to complete those. We also provide a McMaster Health Forum evidence service following each dialogue, which alerts stakeholders to new systematic reviews related to any or all of the elements. So given that this dialogue ran in June 2012, we've now wrapped up that evidence service because it only runs for a year. But the most recent stakeholder dialogue that would be of relevance to this would be one that we convened on supporting optimal screening approaches in Canada, which has some overlap in topics. And that's starting at the end of this month, so you can sign up for that if you wanted for the next year. And then in general, one resource is Health Systems Evidence, which is our database of all the systematic reviews in the world addressing health system delivery, governance, financial, and delivery arrangements. And then lastly, our evidence-informed healthcare renewal portal, which has been developed with a number of partners, including CIHR, which is part of Health Systems Evidence, and it provides access to a categorized set of policy documents related to healthcare, which might be informative for either this topic or others that you might be working on. And then just lastly, my acknowledgements to my co-authors, Francois Thiago and John Lavis, and the funding we received from CIHR for this.
Excellent. Thanks so much, Mike. That was a great overview. And we are going to turn things now back to Heather and John for some next steps for the BC Ministry and really some thoughts on the project itself. And I just want to mention too, you'll see in the chat box that the evidence brief, the links have been provided there as well. You have access to that. So I'll turn things now to Heather to provide the overview of next steps.
Okay, thank you. So what the ministry took from the evidence and knowledge synthesis, both the written report and the deliberative dialogue session, was that the absence of coordinated governance, delivery, and funding mechanisms for genetics and related services actually impedes our ability to make the kinds of changes that the stakeholders discussed and wanted to see at the dialogue session. In particular, the combination of fee-for-service and global funding creates two competing streams for healthcare dollars. And the paradox is that having more testing and duplicative testing actually results in greater revenue generation for providers, and that's a really big structural obstacle to moving ahead into a more efficient and effective system. So in light of the McMaster report, we have had a discussion at our ministry executive committee about the issues of genetic testing. We formed a coordinating committee just within the ministry so that at least decisions that come in and issues that come in through the multiple streams in the ministry, whether it's our pharmaceutical division, the medical services plan, fee for service schedule, the health authority through the health authority division through the cancer agency, and so on, that we're at least aware of and making collective decisions as needed on issues that are arising. We have also been having discussions with the front-end service delivery and experts on these issues and what are the kinds of decisions that we need to make on genetic testing and understanding more about that. I think overall, and if you turn to the next slide, the bigger thing that I think that we're trying to address are some of the systemic issues that were noted that are not different in genetic testing, but that if we address them, we might be able to also, it would have a beneficial effect for the genetic testing domain. So we have been working very closely with PHSA, and in particular John Andruschak, who's here with me, to look at a number of these issues. So one of the big things is, and it was sort of mentioned, was the laboratory reform. The government has committed to reforming our lab system. The specifics of that are still being worked out, but it comes back to the same issues as genetic testing, governance, funding, and service delivery models. So we're just working through those details right now with our stakeholders, and would anticipate that there will be some movement in that and developments in the new year. And that will enable, I think, a more coordinated way to look at the genetic testing. The other area that we've made progress on is the development of a health technology assessment process overseen by a health technology advisory committee, which both John and I sit on with a number of other people from the province. And we've got the process underway to make decisions, commitment from the health authorities to participate in it and abide by the decisions. And we would anticipate that genetic testing issues or genetic issues in general would come to this committee in future. So we have a mechanism now to at least review where evidence is available and bring that to bear on decision making in this area. I think really the key, though, is going to be some facilitated discussion between the ministry, the Provincial Health Services Authority, and other experts on the policy and program decision making and how we will proceed specifically in this area. I think one of the other issues for me that's really clear in this whole area that's perhaps a little bit different than other areas is the speed at which developments and decisions need to be made. The providers out there and researchers are really pushing the envelope and are getting ahead of us sometimes with decision making because our processes are slow and cumbersome. And I think we need to be more nimble and work closely and directly with our partners to be able to address this changing and evolving field and be able to reap the benefits that we hope to get. Do you want to add anything, John, from your perspective at the PHSA?
I think for the most part, what we will help do is be able to kind of help facilitate that. So fortunately, within the PHSA, we're involved with a number of key experts in both research and service delivery in the fields of genetics and genomics, and extending the full gamut. And it's a matter of us being able to bring them together to be able to provide advice in a kind of coordinated manner to the people who are going to advise how policy can be developed. I think the other aspect to this, and Heather stressed this, is just this whole process around the health technology assessment and being able to kind of help ensure that as we add new testing, if you will, to the menu and what tests we will be funding, there is a mechanism by which to evaluate both the science and the evidence to ensure that where that limited resources being applied is going in that area. A number of clinicians are also very interested in trying to look at are there opportunities to work together differently. So as highlighted both in the literature review or the reviews that were done, there's a number of platforms being developed quite independently, and that opportunity for working together, and perhaps quite differently than we have historically, really lends itself to actually being able to not only sustain, but actually innovate and continue to grow and fund, if you will, the capacity to do more testing. So it's going to be key for us to bring those components together. Thank you.
Thank you, John and Heather. I want to open it up for questions now. Just invite questions from participants, both for John, Heather, and also Mike, related to the project itself. And as you're thinking of your questions, I just want to thank the speakers for that overview. CIHR has been very pleased to support projects like this, and as I mentioned, in one of the links, you'll see some of the other expedited knowledge syntheses that have been completed under the Evidence-Informed Healthcare Renewal Initiative. And so I encourage you to go and have a look at those other syntheses, and also to link into other policy rounds like this that will feature some of that work. So again, because we don't have the microphones open for all the participants, please use the chat box to pose your questions, and I will address them to the panelists for comment. Okay, so one of the first questions here, people often comment that genomics is not different than any other technology and should not be treated as something exceptional. What do you think around that? This one's directed to John.
I'm not quite sure how to answer that question, to tell the truth. For the most part, the components that seem to be somewhat different for us in this circumstance are, one, it seems to come from the research environment directly to clinical practice or clinical service. That period of time now is seemingly exponential. It's a much faster moving from bench to delivery, and the need for that. So what we're seeing is on a practical sense is the desire or the need to ensure that the test that we're offering is being validated and then being able to actually be funded and put into place. But because it's coming out at every aspect of medicine and the number of candidates are being identified, we're not able to keep up. It's kind of an unprecedented growth almost immediately in a number of areas. So I think it's sort of largely a matter of not being able to address how fast it's coming to us, and not being in a circumstance of just adding a new test onto an existing platform. So if you have clinical chemistry or hematology or anything, you're doing one more test onto a platform that can absorb it. In this case, we're having to actually create all new platforms and all new testing mechanisms to validate, are these tests in fact being meaningful. So it's just a matter the system hasn't caught up with the demands that are being placed on us.
Thank you, John. Another question. The problems being addressed in this project are common to all provinces. Is there a way to engage other provinces to address common problems such as the HTA process for genetic tests? Which panelists would like to try to tackle that one?
It's John. I would think that there's a huge opportunity. There's some loose collaborations that we've already started on, and I mean there is ones on a professional basis where the collegiality there already is being established to look at the entire issue of the cost per test. So what we described and what we're learning is that there is an ability that if you can effectively address a significant volume, you can reduce the cost of the test. So is there an ability for us to in fact share that in a similar manner to what we're sharing around the health technology assessment? So already we're trying not to, in that process, duplicate anything that's already being produced, through a variety of other sources. So if there is being a valid process undertaken, accept that and being able to adopt it in the BC context and then put it into practice. So I think there's huge opportunities for us to be sharing that.
This is Heather, and just to add to that, CADIT, which is, I actually don't know what the letters stand for, but anyway, hopefully people know what it is. CADIT, who does the drug and non-drug health technology assessment reviews nationally for the provinces, has also indicated that it's willing to look at this issue of genetic and genomic testing and personalized medicine. So I would anticipate that that would be, and we use, as John said, we don't duplicate those processes in our provincial process. We take that information from CADIT and other sources to formulate or to add on for our consideration of the test in BC. I think there's probably other opportunities too around some of the health human resource planning and education and those kinds of areas where there's national effort on in those areas on other kinds of issues, but I don't think it's a top priority issue right now on the federal, provincial, territorial agenda.
We're also, I'm working with a group of clinicians who are establishing a framework by which we can contribute a process to the health technology assessment. So at the moment it's non-drug related, non-pharmaceutical related. We've been doing largely things other than lab testing. So we're trying to put together a framework that works within the context of a health technology assessment framework.
Okay, I think relating to that question, there's one from Shannon. Is there a possibility drive to coordinate this type of evaluation at a national level?
So that would be through CADIT, which is the already existing body for doing this kind of work.
Okay, and next, this one's for Mike. Are you aware of any cost effectiveness or cost benefit studies of specific genetic tests?
So thanks for the question. The scope of the brief was more around the policy issues and not around specific genetic tests. It was more about how do we coordinate and govern the use of tests within the system. So unfortunately, as part of this project, we didn't go into specific cost effectiveness or cost benefit analyses or studies for individual tests. I do know of one economic evaluation of genetic nurse counselors for breast cancer risk, for doing breast cancer counseling and risk assessments. So that's one in terms of more of the system arrangement that's available that could be of interest.
Okay, thanks, Mike. Another question, genetic information is personal information. It's important to be aware of the difficulty in de-identifying this information. Did the team consult with Dr. L. Hammond in Kingston about this issue?
So maybe I'll just jump in here. I don't believe we did consult with that specific person. So indeed, there is a confidentiality issue to be addressed. Again, I guess that was not really part of the scope of it. Again, it was more about the system level and governance stuff, but that certainly comes into play in terms of electronic medical records and health records. So it's not the downplay, so it certainly is important. We didn't, I guess, consult with that particular person that you flagged.
Okay, current HIT vendors for EHRs and EMR are not designed for genomics. Genomics results also seem very much free text. How do we anticipate this and start people working together to think differently? Any thoughts on this one from the panel?
Tell me exactly what the question is. I don't know who asked it, or read it again.
Sure. So I'm not sure of the acronyms. This one's from Alex. Current HIT vendors for electronic health records and electronic medical records are not designed for genomics. Genomics results also seem very much free text. How do we anticipate this and start people working together to think differently? So related to how these are recorded in medical records.
Yeah, I would think that in many of the circumstances where I know in most of the laboratories that we're functioning in have very old and some somewhat legacy systems that are in place and are, as been pointed out, are actually not at a level where at how fast this is actually precipitating. And I believe that what will require is some need to kind of invest in our lab information systems to accommodate this piece of it. But I know that like I don't have any details specifically around this particular element, other than working with our vendors.
Okay, so I'll move along to another question. And if others who are participating also have thoughts or answers to some of the questions posed, please do feel free to comment in the chat box. Wendy has mentioned in the chat, and I'll just highlight this, that there's a group of an active program of HTA and cost effectiveness analysis of genomic testing in pediatrics with reports and ongoing studies being posted, and she's provided the link in the chat box. So I just wanted to highlight that. Another question, this one from Milan Patel at the BC Rare Diseases Foundation. This process sounds like it will take several years to come to fruition. In the interim, what will be done to support today's patients?
So again, I think in many of the circumstances, what we're having to do is put this together in a programmatic structure. And in most cases, if the thresholds are met, in many cases, there are mechanisms by which the testing can get done. I think our biggest challenge right now is the validity of the testing that's being asked for. Will it arrive at the necessary outcome? Will it meet all of the requirements? So that's a whole issue, that entire issue that we're trying to describe around what tests should we be allocating our resources to. And it is something that it is an existing challenge for us to be able to meet all of the requirements at this time. But I think it's the process that Heather described is how we see ourselves getting to some conclusion on it.
Yeah, I would agree with that, John.
Sorry, Heather, did you have something to add?
No, I don't. Nothing further.
Okay, so from Day Tom Kim, in a similar context, I wonder if and how long our current provincial and federal financial arrangements could support genetic testing for the Canadian population itself. Experts' opinion would be appreciated. So if and how long our current provincial and federal financial arrangements could support genetic testing. So
I guess I could say that from a provincial perspective, as I said, right now it's a relatively small portion of our budget. I think our concern is, as we hear, it's growing exponentially, and the cost pressure will eventually, I don't believe it's a financial stress on the system at this time. I think if we get in place the kinds of mechanisms that we've talked about in terms of before we add new tests, we actually do that proper scientific evaluation and assessment, that we will be able to manage it going forward. Particularly, and I think part of the opportunity is there will be cost savings associated with it if you can begin to, the promise of personalized medicine, which is you can actually target drugs and treatments more effectively to people that can benefit them and not provide them to people that won't benefit from them. So I think, it's something we need to keep a watch on, but at this point, at least in our province, it is not the biggest cost pressure, or even a significant cost pressure. And I don't know if John has anything more to add about some of the,
I think in part some of the thinking around the entire lab reform objectives from both in the ministry to maximize the efficiencies in a number of areas of lab service delivery at this time, and be able to effectively reinvest money or create capacity to do more testing. And I think that's our real opportunity as far as being able to get economies of scale in being able to deliver some aspects. And I kind of highlighted this earlier. Is there certain operational components of the sequencing component, or the bioinformatics ability? Are they able to work collectively together? And you gain that kind of an efficiency in being able to deliver more testing and more service stream.
Okay, excellent. And would any of the panelists have thoughts on the implications for training of health professionals? Would an interdisciplinary approach be best, or profession-specific required?
I'm not an expert in that area, so I don't have an opinion on that.
Yeah, this is Mike. I'm not an expert in the area of professional education, but in terms of a more general educational perspective, I think interdisciplinary approaches make a lot of sense, and the fact that genetic testing, it has implications across many different diseases and treatments. Then going forward, for instance, if a positive test is found, then I think an interdisciplinary training approach would make a lot of sense.
Okay, and a question from Jean-Michel. Linked to many challenges in genomics comes the challenge of the management of rare diseases, research support, genetic test availability, drug availability, and reimbursement, patient diagnosis, etc. Is the BC Ministry of Health planning on working on a provincial plan for management of those diseases?
Sorry, can you repeat the question?
So I guess the person asking the question is wondering if the BC Ministry of Health is planning on working on a provincial plan for managing rare diseases in terms of research support, genetic test availability, drug availability, and reimbursement, patient diagnosis.
Okay, not at this stage, but we are planning to meet with the organization in a couple of weeks too. And certainly there's a lot of work within our pharmaceutical division around rare diseases, and this is something that has been raised and worked on at the national level.
Thank you. And just a comment. Work to genetic testing. Laboratory testing more generally is currently an area of focus for CADIS, and they would very much welcome connecting with BC and other provinces to understand evidence needs around genetic tests, priority tests for evaluation, and timelines. So thank you for that. If you want to post a link to all participants to facilitate that connection, that would be great. I'm just scanning here to see if there's other questions I've missed. There are a lot of service providers of genetic services on this call. So what is your reaction to this discussion? What advice do you have for the BC Ministry and the Provincial Health Services Authorities? So we invite you just to indicate some comments in the chat box, please. Would be much appreciated. And while people are thinking of their responses, and not to at all cut off questions, please do keep them coming. I just want to indicate that we have a short survey that will ask each of you just to check off online here when in a few moments. There's just 8 or 9 questions to complete. Okay, so a question from Catherine. There is clear interest in a national approach to many of these challenges. I'm the director of the Ontario Personalized Medicine Network, and we would like to initiate a more comprehensive conversation. If you're interested, she's provided a contact email in the chat box. Thank you, Catherine. So again, while the questions are being formulated, I'm just going to put up on the screen here a short survey for you to complete. The survey will be open for about 5 minutes, and I'd also like to let you know that we'll email all the participants with the slides and a link to the recording. We'll do that as soon as possible. Okay, so the survey appears there now, and I'll just ask another question. This one from Jennifer. Given the array of types of genetic tests that could be used for different purposes, so for example, oncology, tumor typing, rare diseases, and WGS, pharmacogenetics, risk susceptibility for healthy populations, etc. Preconception carrier testing and traditional diagnostics, will these all be considered under one umbrella?
I think that's in fact probably one of the comments or statements that I brought forward. I think that remains for us a bit of a challenge. So at the moment, each of those realms of supporting those aspects of medicine are being established separately, and is there opportunity to bring them together to actually service that need differently? So if we can take advantage of economies of scale, keep our clinicians, our scientists at next gen capability, have our bioinformatics people work together, do we gain an economy of scale that allows greater capacity to serve those needs? So parts of it, as mentioned, are servicing the doing human DNA, and the other aspects are within a microbiology realm, and disease specifics are proteomics and single organisms. So I'm not sure, but I mean the opportunity is definitely how we work together differently. Recently in the Gray Press, there was an announcement from New York of how groups are able to come together and kind of formulate a single enterprise to deliver service stream. And I know that that's common in a number of jurisdictions as a way of trying to address how to make this as increase and maintain capacity and address the economy of the economics of doing this in a sustainable manner.
Thanks, John. Please do feel free to continue asking questions. And if I've missed anyone, I apologize. Perhaps repost it if I've missed a question you've sent. You can repost to all participants. And I guess just a question from here to the ministry. Just wondering if there's anything in the process that really stood out for you as being surprising as you undertook the synthesis and the process that you did. Anything that it was unexpected?
Yeah. I don't think so. I mean, I think the issues of funding, governance, and service delivery underlie many of the issues in the system. I mean, it's an issue we're grappling right now with the whole lab reform and how do we do that. So I think, highlighting the importance of those issues and how you that you need to work through those and carefully think about them, I think was a good reminder to us. But really, they are the basics of a lot of the decision making we make about how we deliver services in this province.
I think the other piece to that was that because the process, and Mike may wish to comment on it, just because it utilized experts from other jurisdictions providing comment, there wasn't one singular answer. There wasn't a panacea, a solution that would kind of get us on our way almost immediately. So I think that's what was evident. So it's presented for us a number of areas and challenges, and it's confirmed them, and it's now a matter of what we need to do, and again confirming a direction to bring it together and seek a resolution to it, or a plan.
Excellent. The questions are starting to slow down. I think people are completing the evaluation, which really appreciate, because it does help us to improve upon these. Some people are posting some contact information and email addresses, so encouraging some linkage and exchange. There's a comment from Shannon. I think that there is the potential engaging in counselors, training, clients and labs, and health providers in this discussion and in educating for health providers. Any thoughts or reactions to that? Question, did you include medicine against clinical numbers?
So, Jennifer, I think your audio is cutting out, so I'm having a hard time hearing you. But the next question was, did you include metabolic technologies in your systematic review as part of personalized medicine? So I guess the answer is no. The evidence brief, as I outlined, was focused on three elements of an approach, which largely focused on decision-making frameworks, quality improvement frameworks, and supporting patient engagement. So it drew on a different set of systematic reviews, so it wasn't focused on specific technologies, but rather on approaches to governing the use of those technologies, so more of a health system governance evaluative approach rather than specific interventions.
Thanks, Michael. Hopefully you can hear me now. This comment from Chris. All the regional genetics programs in Ontario, clinical and laboratory, have organized planning, a coordinated planning activity through the Ontario Genetics Secretariat. As chairperson, we'd be very interested in contributing our planning efforts in a national dialogue. And so Chris's email address is there for you to contact. And I think all of this will get captured, and we'll make sure that it's available for the panelists. So again, I just wanted to let you know that we will email all the participants with a PDF of the slides and a link to this recording as soon as it's available. likely sometime next week will be, but we'll send out the PDF as soon as possible after this webinar. And you've got the email addresses of the speakers, and please feel free to contact myself or Howa Combian. You know, we can help provide linkages to others that have participated on the call. Michael, John, or Heather, any kind of concluding final comments as we head towards wrapping up?
It's actually Victoria Shuckle. I just wanted to say that when we had the stakeholder dialogue, there was a lot of enthusiasm and there was a lot of goodwill in the interviews that led up to that and on the day itself, and that our expectation was that we were going to be able to move quickly, or at least that we foresaw that we were going to continue to move forward. I think we have continued to move forward. It hasn't been as quickly as we wanted, but I know that on the call there are a lot of different people who we've had conversations with over the last year and a half, and just want to thank again CIHR for the work that you did, for McMaster, and to let some of the people both in other provinces but also specifically in BC let you know that we are sincere in really wanting to pull this together in a way that we're going to be able to better capitalize on some of the new science that's coming, but to do so in a more thoughtful, methodical way, as Heather and John spoke about. So I just wanted to make that point. I think that over the course of this, I think this has been a really good policy round, and I just want to make sure that people get a sense that there still is a real strong interest, as John and Heather had indicated. So thank you.
Excellent, thank you, Victoria. And if people want to contact the ministry, is that best done through Barbara?
Yes.
Okay, and we'll, Barbara, is it okay if we put your email address into the chat box?
Yeah, that's fine. Right.
Okay. Okay, so I think that's all the questions that have come through for now.